Promises of palliative care. The United States will be facing many challenges in the near future that will require a balance between competing health priorities. 83.7 million Americans will be greater than age 65 in the next 20 years, with 18 million of those individuals achieving the advanced stage of 85. The sheer number of individuals requiring care, along with spiraling health costs, will require innovative policies to provide ethical, comprehensive, and realistic care to individuals with chronic life-limiting illnesses, far before they enter in the terminal stage. Therefore, a policy that increases funding to increase accessibility, education, and specialty practice certifications of the advanced practitioners and palliative care programs is crucial. Expansion of palliative care programs that utilize a routine screening tool will not only contain costs in the last few years of life, but it will also ensure that patients' dignity, self-worth, and their individual rights to end-of-life care transitions are respected. Innovations in healthcare financing will also be explored to maximize the number of patients that can benefit from palliative care services. A policy change would be to require all hospitals that receive Medicare, and Medicaid funding to offer a structured palliative care program. To accomplish this lofty goal, support of the proposed bill to expand the Hospice and Palliative Care Training Act will require the Department of Health and Human Services to expand funding to provide support for education, training, and the development of palliative care teams. The policy change will allow stakeholders to take part in the coordination of palliative care across numerous settings. The advantage of patients being hospitalized during palliative care treatment allows the interdisciplinary team to have open communication about the countless changes in the patient's condition. This will affect the stakeholders because there will be a decrease in the cost of intermittent readmissions and discharges. This is going to pose a decrease in revenue because the patient's hospitalizations will be monitoring and supported during their hospital stay by the governing body. Palliative care is a component associated with stakeholders to advocate for quality and reasonable services statewide. This multidisciplinary concept is to provide medical services to individuals with incurable diseases. The policy for palliative care is important because it promotes an organized philosophy directed towards symptom relief. It's an additional layer of support for an already stressful situation, allowing the individual and family members to focus on one another while spending quality time together. This policy provides important comprehensive direction to alleviate pain and suffering while lending support spiritually, emotionally, and socially to maintain one's desirable quality of life. This policy manages the transition and episodes of care and patients' abilities to complete their own daily functions and utilize outside resources. A person's decline in health opens the way for specialty services to meet their needs. Many of these patients are hospitalized for symptom relief, and this provides comfort measures. This policy also allows the medical team to focus on the patient's wishes with a clear understanding without diminishing the quality of care. To meet the upcoming workforce needs to support an expansion of palliative care programs in all hospitals will require increased training for staff and specially certified providers competent in addressing end-of-life care. According to Montoya, the number of providers with hospital and palliative care certification at the end of 2015 was only 7,054 providers, falling far short of the needed providers to care for our growing elderly population. Presently, the Affordable Care Act decreased funding available for its end-of-life services such as palliative care. Another issue is related to the lack of realistic provider and patient discussions regarding end-of-life cares in America. Realistic discussions related to advanced directives require time, and current CPT billing codes do not allow for sufficient time to discuss this component of palliative care. Therefore, a critical component of the success of palliative care expansion will also be to lobby for the expansion of the advanced practice nurse's role in leading primary palliative care teams and support of equal reimbursement rates for APNs from all payer sources. The APN is well equipped to provide staff, patient, and family education to dispel the many myths that surround palliative care and prevent its growth in the United States. Discussion of death remains a taboo subject in America. Not addressing the natural deterioration caused by chronic diseases and the natural dying process increases the risk of patients without freedom from all aspects of pain, mind, body, and spirit. While the focus of palliative care may no longer have a curative focus, this type of care does allow for realistic conversations regarding the medical interventions that can increase comfort and maintain the highest levels of health possible with serious illness management. Critical issues to address with patients and families are how to make informed decisions regarding nutrition and hydration, freedom from pain, advanced directives such as DNR status, and timing for assigning on to these expanded services. It has been well documented that almost 30% of Medicare dollars are spent in the last 2 years of life, with the greatest expenditures in the last few months or weeks. According to Vandy Hovel and Olanaru, the expansion of palliative care services is one way to decrease the burden of chronic illnesses on the healthcare system while continuing to provide quality care management. The Centers for Medicaid and Medicare Services guidelines currently focus on group bundling for diagnosis-related groups in healthcare financing and offer minimal diagnosis models for palliative care. Applying cost-benefit analysis in relation to adjusted quality of life years is another method for determination of the cost-effectiveness of palliative care. A stellar example is the California-based Sutter healthcare system that is utilizing a $13 million federal grant to reform their palliative program in 24 sites. Their innovative program, Advanced Illness Management, or AIM, works to identify patients that would benefit from coordinated care, thereby reducing hospital visits and enhancing the quality of life for individuals with chronic disease management needs. For the patient, palliative care teams that are initiated in the acute care setting can even translate into slightly greater than 3 quality living years when enrolled in a palliative care program. Additionally, from Sutter's program alone, almost $9,000 per patient were saved for the payer, and they are anticipating a $29 million savings to the Medicare system. Imagine the potential savings to the entire American healthcare system if funding expansion was secured from the proposed bill for the Hospice and Palliative Care Training Act for early interventions with palliative care teams. Support of the expansion of the proposed bill to expand the Hospice and Palliative Care Training Act will allow patients to live a better quality of life without heroics when the end of life comes. Most of these people have their families at the bedside at the end of life, making a hard situation bearable because they are together during the person's last days. This is where palliative care teams allow them to share their love while bringing them together in comfort for the final days. Palliative care has been known to decrease hospital costs because of the number of hospitalized days are reduced. In some cases, therapeutic interventions such as diagnostic testing are no longer utilized unless symptom relief is needed. One's decision to extend life with a degree of discomfort and suffering is part of their value system. This is where quantity of life is weighed against the quality of life, making it subjected to a person's own value system. Naturally, the clinical team members providing palliative care have their own values and belief systems, but each member must be educated to honor and respect their patients' and families' decisions, even when they conflict with their own. Many families have been made to believe that palliative care is not covered by insurance companies, which is not factual information. Some insurances, Medicare and Medicaid, cover palliative care services in rehabilitation centers, hospitals, and skilled nursing homes, but some facilities don't use the term palliative care because the services rendered are the same. Finally, this is a way to be symptom-free and live life to the fullest until the end.